Hey everyone! Today's lesson from ACLS Certification Association is on care of the patient with the shockable rhythm. Don't forget to visit us online at aclscertification.org to certify or recertify your ACLS, PALS, BLS, or NRP 100% online. Now, let's get started. Care of the patient with the shockable rhythm. This section of the cardiac arrest algorithm details the general care of a patient with a shockable rhythm, such as ventricular fibrillation, or VF, or pulseless ventricular tachycardia, or PVT. Ventricular fibrillation is a disorganized and chaotic rhythm, while pulseless ventricular tachycardia represents an organized rhythm. Neither, however, generate the blood flow required to sustain life. For this reason, both are classified as lethal rhythms. Survival relies on three groups of interventions: basic life support, advanced cardiac life support, and post-cardiac arrest care. Success is attainable if the victim receives early high-quality CPR and rapid defibrillation within minutes of collapse. Other notable interventions include administration of intravenous epinephrine and airway management with advanced airways, which have been known to increase the rate of return of spontaneous circulation, but not survival rates to hospital discharge. The 2015 algorithms created by the American Heart Association were redesigned to be simplified with a great emphasis on high-quality CPR. Interruptions in chest compressions must always be minimized and are only necessary to assess rhythm, shock VF or PVT, perform a pulse check when an organized rhythm is detected, or place an advanced airway such as an endotracheal tube. Monitoring the patient's physiologic parameters that aid in assessing CPR quality is recommended. These include partial pressure end-tidal CO2 or PET CO2 monitoring, arterial pressure monitoring during the relaxation phase of chest compressions, and central venous oxygen saturation, SCVO2 monitoring. Defibrillation. In most cases of cardiac arrest, the first provider immediately starts CPR with chest compressions, while the second provider retrieves the defibrillator, attaches its pads to the patient, and checks the rhythm. The pads are placed in direct contact with the skin at the anterior lateral aspects of the chest. Alternative positions include anterior-posterior, anterior left infrascapular, and anterior right infrascapular regions of the thorax. The recommended defibrillator designs are 1. Biphasic truncated exponential, or BTE, and 2. Rectilinear biphasic, or RLB. These technologies offer different peak currents at the same energy settings. The energy outputs adjust based on the amount of impedance from each patient. The defibrillators with the RLB waveforms deliver more energy than the selected dose, because energy is based on patient impedance. A selected dose of 120 joules would provide about 150 joules for most patients. Studies have shown that the BTE and RLB defibrillators are highly effective in converting shockable cardiac arrest rhythms. The energy setting for the first shock must be based on the manufacturer's settings. First shock success is defined as the termination of the rhythm at 5 seconds after shock delivery. There's a success rate between 85 to 98% when the energy setting of both BTE and RLB is 200 joules or less. Rhythm-based management. Rhythm checks must be brief. Remember that pulse checks and rhythm checks are performed in 10 seconds or less. If the provider is not sure that he or she can feel a pulse, they should immediately perform chest compressions. Go to the rhythm-based management video for more details. Ventricular fibrillation. In ventricular fibrillation, there are multiple areas in the ventricles that are depolarizing and repolarizing in a chaotic manner. This causes a loss of the pumping action of the heart. The ECG will show signs of voltage fluctuations. Coarser waves represent high-amplitude waves, while fine waves represent smaller amplitude waves. Early in its course, ventricular fibrillation has coarser amplitudes. Left untreated, these coarse waves will transform into finer amplitude waves until the victim converts into a systole. The heart rate in ventricular fibrillation is very rapid and chaotic. The QRS complex cannot be appreciated. Likewise, the P wave is absent. Pulseless ventricular tachycardia. In PVT, the heart rate is fast with a regular rhythm. The QRS complex is wide, and the P waves are absent. In order to be classified as VTAC, there must be 3 or more beats of ventricular origin in a row. Sometimes a P wave is observed, but it is not related to the QRS complex. It is difficult to differentiate ventricular tachycardia from supraventricular tachycardia with aberrant conduction. When in doubt, always assume that the patient is in ventricular tachycardia. Shocking the victim. Once ventricular fibrillation or pulseless ventricular tachycardia is confirmed via AED or ECG monitor, deliver a shock. Charge the device. While charging, CPR continues. Once charged, it is imperative to clear the patient. Ensure there are no personnel touching the patient, the gurney, or any equipment attached to the patient, and deliver the shock. Immediately following the shock, perform high-quality CPR for 2 minutes before checking for a pulse. As noted, the chance of first shock success is high. Of course, this is dependent on how long the patient has been down. If the first shock fails, it is reasonable to give another shock after 2 minutes of CPR. Follow the defibrillator manufacturer's instructions for shock dosage. Studies have shown that a peak current of 150 joules fixed BTE or RLB waveforms can terminate persistent ventricular fibrillation. There is no change in return of spontaneous circulation or survival to hospital discharge when a fixed dose is given versus an escalating dose. However, if a provider is using a defibrillator that allows for adjustment of the energy dose, then the provider may opt to increase the dosage for the second and subsequent shocks. The single shock strategy with continued CPR for 2 minutes right after giving the shock is preferred over the stacked shock strategy. Intravenous access. The purpose of epinephrine and other antiarrhythmic medications is to facilitate a perfusing spontaneous rhythm. An intravenous cannula or intraosseous cannula can be used to rapidly deliver fluids and medications into the central circulation during CPR. Consider inserting an intravenous cannula after providing the first shock, while minimizing interruptions in chest compressions. If intravenous access is not feasible, use intraosseous access. The medullary sinusoids of long bones are more than adequate to deliver these medications to the central venous circulation. These sinusoids are resistant to collapse. When deciding upon when to gain an IV or IO access, the following is a guide. High-quality CPR supersedes defibrillation, and defibrillation supersedes establishing IV or IO access. Other access for cardiac arrest drugs. If intravenous or intraosseous access cannot be established, the next step is central venous catheterization. Central venous catheterization directly delivers the drug to the central circulation after gaining access through the subclavian or internal jugular veins that extend inferiorly towards the superior vena cava. The central line can also be a conduit for physiologic monitoring, such as central venous oxygen saturation and central pulse pressure to assess the quality of CPR. These are also used to predict ROSC. However, central line placement can cause a prolonged interruption in chest compressions. It is also a relative contraindication for fibrinolytic therapy if needed for ischemic stroke and acute coronary syndromes. Absorption of drugs via an endotracheal tube is possible for naloxone, atropine, vasopressin, epinephrine, and lidocaine. Remember navel. No studies have been done to determine the absorption efficacy of amiodarone. The endotracheal route results in lower blood concentrations when compared to the intravenous route. For epinephrine, this can increase the beta-adrenergic effect of the drug and cause vasodilation, which can lead to hypotension and lower coronary pulse pressures and flow, thereby reducing the potential for ROSC. The dose of epinephrine administered via the endotracheal route must be 3 to 10 times the intravenous dose to achieve the same effect. It must be diluted in 5 to 10 mL of a sterile normal saline solution and then injected directly into the endotracheal tube. Epinephrine. Epinephrine is an alpha-adrenergic drug that causes vasoconstriction. It is used to increase coronary perfusion pressure and cerebral perfusion pressure during CPR. Epinephrine is given at a dose of 1 mg IV or IO every 3 to 5 minutes during cardiac arrest. Giving higher doses of epinephrine, while seemingly logical to improve coronary and cerebral perfusion, may cause more harm than good. At higher doses, the beta-adrenergic effect of this drug increases myocardial workload and decreases subendocardial perfusion. When administering the drug, the provider must follow the bolus intravenous injection with a 20 ml flush of normal saline to facilitate the movement of the drug from the peripheral circulation to the central circulation. The provider elevates the extremity where the drug was administered to allow gravity to assist in the delivery of the drug. Airway management. All patients in need of CPR must be provided with positive pressure ventilations via a bag valve mask device with supplemental oxygenation at 100% concentration. During the first few minutes of witnessed cardiac arrest, blood will have an adequate concentration of arterial oxygen. Positive pressure ventilation is needed less during this time, and chest compressions are more important to circulate oxygen. When providing bag mask ventilations, make sure that there is someone to help, if possible, in opening the airway and producing a tight seal against the victim's face to prevent air leak during delivery of each breath. Mouth-to-mouth or mouth-to-mask ventilations are recommended for lone rescuers. Deliver about 600 mL with each breath. Adequate ventilations can be assessed by observing for visible chest rise after each breath. After the second shock, healthcare providers should consider the placement of an advanced airway. Ventilations and chest compressions are important for victims who suffer a prolonged cardiac arrest. Normal ventilation-perfusion relationships can be maintained by providing positive pressure ventilations while performing CPR. An advanced airway allows for asynchronous ventilations without interrupting chest compressions for breaths. There is, however, no advantage other than decreasing interruptions in chest compressions when providing ventilations via bag mask device versus ventilations through an endotracheal tube. All providers must be proficient in providing positive pressure ventilations using a bag mask device. Refractory ventricular fibrillation and pulseless ventricular tachycardia. After the third shock is given, providers can contemplate using amiodarone. A 300 mg bolus is given for refractory ventricular fibrillation, or pulseless ventricular tachycardia. A 20 ml saline flush can help facilitate the distribution of the drug to the central circulation. If the first dose is ineffective after the next shock and a 2-minute round of CPR, a second dose of amiodarone, 150 mg, may be given. Outcome. If the patient recovers and achieves return of spontaneous circulation, then clinicians should proceed to post-cardiac arrest care. If the patient does not improve after the aforementioned interventions have been tried, then providers should think about the possible reversible causes of cardiac arrest. We refer to these as the H's and T's. Prognostication during CPR. If a patient is intubated, we can measure the patient's response to interventions by utilizing waveform capnography. The output is the end-tidal CO2 measurement. End-tidal CO2 is the partial pressure of exhaled CO2 produced from gas exchange within the alveoli of the lungs. This represents possible blood flow to the pulmonary vasculature as proof of good ventilation and perfusion of the lungs. Low end-tidal CO2, less than 10 millimeters of mercury, can indicate that CPR must be improved. It can also prognosticate a poor outcome if it remains low despite 20 minutes of high-quality CPR. Persistently low levels of CO2 while providing CPR may indicate a problem with the equipment, such as a kinked endotracheal tube, or physiologic disease such as tension pneumothorax. That's it for our lesson today. Thanks for watching, and remember to check out our website at aclscertification.org for more free content or to get certified or recertified online.